We're thrilled to welcome you all to another inspirational and educational episode of Concorde Conversations. Concorde Conversations is an initiative by Concorde Medical Group to educate, empower, and encourage our community about our health so we can all live to our fullest potential. Today's episode is Breaking Ground, New Insights in Understanding Menopause. Hi, I'm Dr. Kathryn Rutenberg, Director of the Adult Congenital Program at Concorde Medical Group, Northwell Health. And today we are joined by our renowned colleague from Northwell Health and faculty of the Zucker School of Medicine at Hofstra University. I would like to introduce you all to Dr. Kathryn Rutenberg. She is a board-certified gynecologist and Menopause Society Certified Practitioner. Many of our Concorde community have submitted excellent questions for our expert today. If you have any questions, please ask them in the chat box. We only have 30 minutes together, so we're going to go through as many as we can. Remember, we're giving general guidance. So if you have a particular question about your health, we'd like to help you. So come in and talk to our exceptional Northwell Health physicians so we can answer your questions and give your health the attention it deserves. So let's get started.
Dr. Rutenberg, want to tell us what it means to be a Menopause Society Certified Practitioner?
Yeah, great question. The Menopause Society used to be called the North American Menopause Society, and they recently changed their name to the Menopause Society. So by the way, being non-certified is the same thing as Menopause Society Certified, by the way, because that's just a new nomenclature change. But it's basically the Menopause Society, and it's mostly in North America. But now I think they also, do work with colleagues in Europe. They kind of all get the best minds in the field, the best experts, and they come up with protocols, recommendations, and then they put out all their literature. And if you want to become a certified practitioner, you have to read their Bible, basically, their menopause Bible, and then take a certification test. And so I did that actually this past year. And I also went to the Menopause Society conference. It was in Philadelphia this year. It was amazing. And I just literally sat for like three to four straight days learning about menopause all day long. And it was actually a lot of fun. And so then I took the test and passed, and that's how I became a Menopause Society Certified Practitioner, which, by the way, is the same thing as a non-certified practitioner. And I have to say I do have to say that certification is important and helpful because as women kind of know now from articles about menopause as of late in this past year, it's amazing how little training we do get in medical school and residency. So this extra training was like really a blessing, and I worked very intently on getting it. It was not like an overnight thing. It was something I had to really work towards for the better part of this fall. That's what it's all about. Hopefully that explains for listeners.
Let's start with something very basic. What is menopause?
Great. Well, I love to talk about menopause. I find it a very fascinating topic. So basically, there's the long answer and the short answer. The short answer is menopause is a very set point in time, and that point in time is 1 full year from the final menstrual period, or the FMP, as we'll be calling it sometimes. And that actually defines the start of menopause, and then a woman is considered postmenopausal from there on out. But interestingly, it's just that one point in time, that one day when it's been a full year from a period. But really, menopause is the whole transition leading up to that, which can be some years, often starting in mid-40s, of changes in menstrual cycle and also sometimes symptoms. One of my favorite descriptions of this sort of menopause transition is by one of the best OBGYNs in the country, Dr. Jen Gunter, and she calls it basically like puberty in reverse. And I do think that that's an apt statement, because as with puberty, you start, and it's a gradual process of change, and sometimes abrupt, and sometimes has its highs and lows and difficult moments. And then on the other side of that, you do feel like your body has somewhat fundamentally changed. So I do feel like it is a bit akin to puberty in reverse.
Okay.
But it's really just like the endocrine, somatic, psychosocial changes that mark a woman's midlife. And just to further characterize when women should expect it, it's average age 45 to 54, but we do sort of peg menopause as coming even between the ages of 40 and all the way up to 58 is the rough sort of age range that we see menopause.
So what is perimenopause?
So perimenopause are those years leading up to that final menstrual period, that FMP. And then again, like I just explained, officially being in menopause 1 year from the final menstrual period. But a lot of the symptoms and side effects can happen in the perimenopause, and those can last even for some years. And there is what we call the early perimenopausal period and then the late perimenopausal period. And the early perimenopausal period, sometimes periods aren't that irregular yet, but women can start to have symptoms. The classic would be vasomotor symptoms, which are hot flashes and night sweats. In the second part of the perimenopause, so the later for a few years, are when menstrual cycles can start to skip, or they sometimes actually get closer together and then skip, but skip for a month or more. And that is also when sometimes we are able to detect more blood work abnormalities as well. And so that's the period of time when sometimes we'll be doing blood tests to kind of try to figure out where a woman is in her transition. And then the symptoms can kind of ramp up in that later perimenopause phase.
So should women get blood tests to check if they're in perimenopause? Should she get her hormones checked?
That's a common question. I do think that there is a bit of misunderstanding about hormone checking in the perimenopause. And the reason is because the classic blood test to check for perimenopause, the classic one is FSH, and that stands for follicle stimulating hormone. And that is the hormone that when I was explaining the early and then the late perimenopause. Sometimes that hormone level doesn't become abnormal until the late perimenopausal stage. And so blood work can be a little bit tricky. That said, I don't think it's wrong to ask your doctor to do some blood tests, but I just wanted to explain that some of those blood tests don't look so abnormal until you're getting towards that later phase of the perimenopause transition. And just for listeners to know, we're looking for that the classic menopause blood test, and there are others, but the classic is that FSH test, and that is greater than or equal to 25 on 2 separate occasions. That really starts to be classically associated with getting close to like menopause.
What are common symptoms of menopause? What are vasomotor symptoms?
There's a lot of great podcasts out now, and I meant there's I think I was listening to one and it said that there are officially on record something like, I may be misquoting the number, but like 85 possible symptoms of menopause. That's extraordinary, right? So I have to say, when I was studying menopause, one of the things that really impressed me was this statement: estrogen receptors are ubiquitous. And what that means is estrogen receptors are present in all tissues in our body. They're present in our brain, they're present in our joints, they're present in our vaginal tissue, our uterus, our breasts. So some of the symptoms women have can be body-wide, but the absolute classic symptoms we ask patients about are vasomotor symptoms, also vaginal dryness, insomnia, and mood changes. But let me go back to the vasomotor symptoms first. And so vasomotor symptoms are 2 things: hot flashes and night sweats. Really, they are kind of the same thing. The difference is that with the night sweats, you experience a hot flash while you're under the covers at night, which leads you to have sweat and have to throw off your covers. And it can be really annoying because then you kind of get cold after the sweat dries and have to throw the covers back on. But really, a hot flash during the day is the same kind of thing. And it's interesting. I mean, the pathophysiology of hot flashes I find fascinating. It has to do with like this pulsatile follicle stimulating hormone, and that it keeps telling the central nervous system, the brain, basically the hypothalamus, to vasodilate. So what happens in a hot flash is a signal is sent and your skin, your blood vessels sort of vasodilate. And what that does is it sends a lot of heat to your skin. And what happens is that feeling of hot flush. And some women, and some women experience then a sweat. They break out in a sweat. The sweat can typically be kind of face, neck, and upper body areas. Not all women will break out in a sweat, but some women do. And when you do have night sweats that are leading, or hot flashes that are leading to sweating, those are the more troublesome ones. And, interestingly, about 80% of women who are in menopause will experience some vasomotor symptoms. So that means most. Now, there are those lucky women that won't. There's a lot of women that find them mild, they're not really noticeable. But for women that have the really noticeable hot flashes with the sweating, we call those women super flushers. And the good news is there are therapies, there are treatments, there are medications and things we can do. So I do just want to absolutely encourage women to talk to their healthcare provider, or ideally like a menopause certified practitioner like myself, about how to cope with these issues.
Yes. How many years do the symptoms of menopause last?
So unfortunately, they can last for years, sometimes even more than a decade. But we do talk about some of the more severe symptomatology range being in the 3 to 8 year range. So it is a while. Again, not all women will experience symptoms. And interestingly, the vasomotor symptoms are common in that late perimenopause transition, but even more common in those first few years after a woman is officially in menopause. That's when the symptoms can be the worst. However, they can linger for several years, even into the 60s.
Got it. So what is hormone therapy and what are the different types?
Hormone therapy is quite complicated because there are so many different types of hormone therapy. One thing I'd like to do is just a quick nomenclature lecture here for a second, because I found this, I have to admit, even I didn't know this until I became a menopause certified practitioner. But for menopause women or in perimenopausal women, we actually use HT, which stands for hormone therapy. And that is different from, that's the new accepted nomenclature. For a long time, I think it was HRT, which stands for hormone replacement therapy. But interestingly, the Menopause Society experts agreed now to use the phrase HT, or just hormone therapy, for women who are in perimenopause or menopause. And that's because we want women to, words are important, right? So we want women to know and understand that it is normal and natural and expected to have your estrogen levels decline when you are in perimenopause and menopause, which is typically in your 40s, mid 40s to 50s. And so using hormones is not replacing anything that's missing. Rather, it's just using hormones as therapy or as treatment for symptoms. Interestingly, hormone replacement therapy is important for women who have premature ovarian failure, which is also known as premature menopause, and that's menopause before the age of 40. So I just want to start with that little nomenclature lecture that we do call hormone therapy in postmenopausal women. Even I still keep calling it HRT a lot, but it's really HT. Okay, so HT is generally, there are different types of hormones, but it's generally estrogens and then progesterones for women that have a uterus. If women don't have a uterus, they don't need the progesterone. But the progesterone is used to protect the uterus from endometrial thickening, which could lead to hyperplasia, which could lead to endometrial cancer. And the progesterone helps prevent that. If women don't have a uterus, they can use estrogen alone. The whole history of HT is kind of interesting. It started to gain popularity in the 1970s, actually. But it came to a screeching halt, as many of your listeners may know, because this is pretty common knowledge, in 2002. And that's when the WHI study halted, and everyone panicked because it had shown some concerning things, like increased risk of breast cancer, which were kind of later debunked. And that led to a screeching halt in hormone therapy use in 2002. But interestingly, I have to say for my listeners, I really want them to know that the pendulum has now really quite a bit swung in the other direction. And we really are excited about hormones and have been using them a lot more. So there are contraindications, but which we can maybe get to. I think that was another question we had today.
What are the benefits of hormone therapy?
A lot of people don't realize that hormones are approved by the Menopause Society and the FDA for just two main purposes only, but they have a myriad of other helps. The two things that it sort of has official approval for are the treatment of symptomatic vasomotor symptoms, and number two, the prevention of bone loss. So a preventative measure for women that we're worried about are going to develop bad osteoporosis, and which could lead to bone fractures and the like. So interestingly, it's officially approved for only those two things. However, I do see in my patients a myriad of other health benefits. For me, the biggest one is mood changes. So women in the perimenopause and menopause experience mood changes, maybe brought about by their sleep disturbances. You know, if you're not sleeping well, it's hard to be peppy and positive. A lot of the classic thing I hear described, interestingly, from my patients is just like a feeling of anger and rage, you know, that's new for them. They don't feel like themselves. And I feel like hormones can sometimes be really helpful with those symptoms, interestingly. Even things like not tremendous evidence of efficacy, but in helps with things even like maybe joint pain. That's another menopause symptom. Definitely can help with sleep because of, a lot of times we think it's because of vasomotor symptoms at night that are disturbing sleep, but they can really help with sleep. Some people feel like their skin is better, hair is better. So they have a lot of potential benefits.
Who shouldn't use hormone therapy?
So it is definitely a careful conversation with your healthcare provider. There are some absolutes, just for listeners out there to know. These would be some of the absolutes, no starters for hormones. And that would be abnormal vaginal bleeding. So what basically that means is, like, do you have any endometrial precancers or cancers that haven't been diagnosed? But that's a pretty straightforward one. The next one is also kind of obvious. Known history of breast cancer. So if a woman herself has breast cancer or a history of it, in general, and there actually are interesting exceptions, but in general, that is not generally a hormone therapy patient. Any patient that has had a history of a recent deep vein thrombosis, stroke, heart attack, so blood clots, recent blood clots. A known estrogen-dependent cancer. So there are estrogen-dependent cancers besides the breast, namely uterus. And then the last one that they mentioned is pregnancy, but that seems kind of obvious. You wouldn't take hormones if you're pregnant.
If you can't take HT,
Yes.
what are alternatives for vasomotor symptoms?
So now I get super excited and kind of like science nerd out because there is a brand new medication out there. Patients might have heard some commercials about it, but the new medication on the block, the new kid on the block, is Veozah. That's spelled Veozah. The scientific name for that is fezolinetant. Fezolinetant is an amazing drug. I really love the story of how the drug came about. It was inspired by scientists that were at the menopause conference like years ago, and they were talking about the thermoregulatory system in the brain called the hypothalamus, and how, what if we came up with a way to target that system just directly and block it? And that's exactly what they did. So just to be scientific for a second, it's an NK3 receptor antagonist. And so what it does is it antagonizes the receptor that's sending those signals to hot flash. And so it is not a hormone. And that's exciting because it can be used in women who otherwise couldn't take hormones. And the other thing I love about it is that it does work pretty quickly. Its onset of effectiveness is often within a week to even a few days, which is exciting. By the way, hormones can take 8 to 12 weeks to kind of work. So I want listeners to know that. But anyway, back to Veoza, it can work pretty quickly. The other thing that I find really exciting about it when reading the medical literature about it is that even when discontinued, the benefits may linger, which is exciting to me. The main downside with it is that it can cause some elevated liver function tests. So the drug maker does advise patients to check liver function tests before starting and then every 3 months for at least the first year. So anyway, that's the new kid on the block. There are other treatments for vasomotor symptoms. The classic ones that are approved by or recommended by the Menopause Society are SSRIs. So that's selective serotonin reuptake inhibitors. That's the one that's FDA approved for hot flashes, night sweats is called Bristol, which is paroxetine. But things like Prozac or Zoloft may also be helpful. Interestingly, sometimes when I have patients on an SSRI and they're going through menopause, I say, "Oh, you might be having worse or hot flashes because you're on that medication that actually might be helping." So that's one of the classic alternatives. There are some herbal remedies, which I'm not going to get into just because there are so many herbal remedies. And here's a really interesting one for listeners that probably many people didn't know, but one completely non-medication item that seems to help is cognitive behavioral therapy. So that's like a form of psychotherapy that can sometimes be helpful and actually has been shown in studies to be a little bit helpful. So that's like a completely non-medication remedy.
So what are bioidentical hormones?
Awesome question. Great question. So many misconceptions about this, right? So I have like amazing news. A lot of the just FDA approved pharmacy given hormones we use today in our new menopause world really meet the criteria to be bioidentical. What that means is they're chemically identical to hormones produced by the female body, primarily produced by the ovary during the reproductive years. The classic estrogen is actually technically called 17 beta estradiol. That's our most potent estrogen. And so we do, it's kind of a misnomer that you need to get bioidentical hormones from like a special natural compounding pharmacy. The experts in the field really, a lot, myself included, are believers in using FDA approved estrogens and progesterones, and there are bioidentical forms of that available. It is a misnomer that you have to use some sort of like quote unquote natural product. So in fact, yeah, the Menopause Society said that they even characterize that they're thinking that it's a bit of a marketing ploy to call these hormones bioidentical. And I think again, I'm glad to clear up a misconception that a lot of the hormones that we prescribe that have been studied and even investigated by the Food and Drug Administration are bioidentical.
When is it too late to start hormone therapy? And what are the downsides of hormone therapy?
This is a meaty one. Okay, the Menopause Society has revised their statements over the years. The current statement is, for most women, it may appear that the benefits of hormone therapy outweigh the risk if a woman starts it within 10 years of menopause or before the age of 60. So that is our new sort of statement. So if I have a patient who comes in 70 years old, I'm not likely to put her on hormones. That's not the patient I'm looking for. I'm looking for those patients in their 50s or in the perimenopause transition, menopause transition. There isn't a lot of evidence yet to guide us as to when patients should come off hormones, but generally in their 60s, early 60s, age 60 or so, we start thinking about maybe coming off hormones. Again, not a consensus in the data, but that's kind of, so we don't intend on leaving women on hormones forever. That said, I do have some women that elect to stay on hormones into their 70s, and we do just carefully go through each year the risks and the benefits and the alternatives. But what are some of the risks with hormones? In the WHI study, that was the sort of scary one that was halted. Now they think that some of the downsides to hormones they were seeing were in older patients who were already sicker. And that's why the whole thinking on hormones has been revised, and we think it is safer for younger women. But there were some risk of stroke, clots, heart attacks. And then there was this purported increased risk of breast cancer. And that's the thing that really scared everyone off. And but I have great news. Really, we think that risk was over touted. At best, it might result in one case per 1,000 women extra of breast cancer. So we consider that pretty negligible. So that's a great misconception I would like to clear up. And by the way, I want to also mention another thing I was hoping to mention in this podcast somewhere is that if a woman has a family history of breast cancer, that is not a contraindication for hormone therapy, by the way. I just want to mention because that's also a common misconception.
How does menopause affect a woman's sex life and libido?
It definitely can. I think the most common way it does do that is through vaginal atrophy, which is vaginal dryness. The tissue in the vagina and vulva is less elastic, less estrogenized, and also can lead to pain with sex. And I think that is often the etiology or the cause of why women have some sexual issues in menopause. The good news is that there are things we can do about it. I was chatting a lot about hormones, but by the way, there is a whole other separate category of vaginal only hormones. So vaginal only hormones are amazing. They aren't very absorbed into the body, and so they can, in theory, be used for an even broader range of women. And so that is an excellent therapy for some of the vaginal symptoms of menopause. I do advise patients to talk with their, healthcare provider, gynecologist, or menopause expert about that, because again, it's there's many different types of hormones that can be used. There's also non-hormonal vaginal remedies. A new very popular remedy is something called hyaluronic acid suppositories. Those are very popular and totally non-hormonal.
So if you had one action step to recommend to our viewers to start today and improve their health, what would it be?
Great question. I have an absolute one word and immediate answer, and that actually is exercise. I'm a big fan of Dr. Peter Attia, Attia. He is a sort of longevity expert. He's a physician. He's pretty amazing. He's got some great stuff online. And it's funny. That was going to be my answer for that question anyway, but I happened to listen to a podcast of his last night, and that's the first thing he said. And I was like, wow, we're on the same page, Dr. Attia. He talks about the health benefits, not just being for obviously, your heart and your weight, but it's like for your brain, for your mentation, for your mood. Yeah, definitely exercise is my go-to advice.
Well, as a cardiologist, I can endorse that advice. So thank you all for joining us for another inspirational and educational episode of Concorde Conversations. A very special thank you to Dr. Rutenberg for joining our conversation. We appreciated her expertise to educate, encourage, and empower our community. As part of the Concorde community, we hope you'll share in our mission. Please pass along our emails and webinar links to help everyone live to their fullest potential. In addition, please like and subscribe to our YouTube channel. We know you have additional questions about your health, and we want to help you. So come in and speak to our exceptional Northwell physicians about your health. We care about your health. We care about you. Thank you so much for joining us today.
Thank you.